like to thank Mary Lee, Phoenix, and Sonia for inviting me to give this talk today, and I'm so excited to be talking to you about medical management of obesity. These are my disclosures. I have had contracted research for these companies and companies previous to this, and these are the companies that I currently consult for. So there are multiple components of a comprehensive obesity treatment program, and that includes lifestyle therapy with diet, physical activity, and behavior modification, bariatric endoscopy and pharmacotherapy, and bariatric surgery. I'm going to focus my talk today on lifestyle therapy and pharmacotherapy, with first talking about lifestyle therapy including diet, physical activity, and behavior modification. So we're going to talk about diet first, and ideally, dietary changes would be long-term. So we want chronic alterations. Intermittent changes that are repeated based on a long-term plan can also be done. Ideally, dietary changes will promote health, and food choices that reduce risk of chronic disease or promote longevity will be consumed. Calorie deficit is needed in order for weight loss, so that is something that is consistent regardless of what macronutrient component diet you're consuming. And calorie intake influences the effect of micronutrients on markers of health. So weight loss phase is typically associated with improvements in cardiometabolic risk factor across different macronutrient diets and regardless of what you're eating. But weight maintenance phase has less beneficial effects on cardiometabolic risk factors and is a little more dependent on macronutrient components. And in the weight gaining phase, we may have worsening metabolic risk factors, and macronutrients may have more of a negative effect in that regard. Multiple diets have data, but there are common themes across these different diets. They have a reduction in either the type or the amount of food that's consumed. They reduce or eliminate sweets. They reduce or eliminate sugar-sweetened beverages, and they use whole grains when grain products are consumed. And again, the macronutrient components of the diet may not actually matter. This is from the Pound's Law study, and they had 4 different diets that were able to compare high protein to low protein, high fat to low fat, and high carbohydrate to low carbohydrate. But what you can see is that there's no significant difference in weight loss from the different compositions of the diet. There was, however, a difference in the amount of weight loss based off of how often the patients came in to do their study visits. So the more behavior coaching that they got, the more weight loss that they were able to achieve. And this has been consistent across other studies as well. This slide looks at data from a network meta-analysis that compared different named diet programs. And they included 59 articles with over 7,000 patients. And they saw that there was significant weight loss for both low carb and low fat diets, but the difference between the named diets was small and likely not clinically significant. So we're going to touch on the different effects of different macronutrients. And we're going to start here with protein supplementation. And this was a study that looked at protein supplementation on insulin sensitivity in postmenopausal women. And they had women on either a regular protein diet of 0.8 grams per kilogram body weight per day or a high protein, which was 1.2 grams per kilogram body weight per day. And what they demonstrated is that there was no difference in weight loss. And they got significant weight loss, 10% total body weight loss in both groups. There was slightly more improvement in intrahepatic triglyceride content in the patients on the high protein versus the normal protein, but they also had negative outcomes as well. So we expect that skeletal muscle insulin sensitivity is going to improve with this much weight loss. But the high protein diet abolished that. So the protein supplementation was negative for the weight loss effect on skeletal muscle insulin sensitivity. High fat diets may also have negative effects. This study was a study looking at isocaloric ketogenic diet versus baseline diet, and it was a crossover design. So they were on a baseline diet for 4 weeks, and then the isocaloric ketogenic diet for 4 weeks, and then within that time, they also got test meals. And what they saw was a slight amount of weight loss on the ketogenic diet, but they had worsening of glucose area under the curve with their control meal test while on the ketogenic diet. So if you weren't eating completely ketogenic all the time, you had worsening in glucose control. There was also an increase in CRP, and although triglycerides decreased, there was an increase in LDL and an increase in total cholesterol. So, what can we recommend? This was the PrettyMed study that looked at the Mediterranean diet, and this was actually a weight stable diet. So, there wasn't any weight loss associated with the diet in either the control, the Mediterranean diet supplemented with extra virgin olive oil, or the Mediterranean diet supplemented with nuts. But what you can see is that there was a significant reduction in the primary endpoint of cardiovascular disease, and that included acute myocardial infarction, stroke, or death from cardiovascular causes. And what about carbohydrates? This is a huge study, 2 cohorts, the larger of the cohorts being over 400,000 patients, and it looked at all-cause mortality. And what they found is that the lowest all-cause mortality was with a carbohydrate intake of 50 to 55% of total calories, with the caveat that the risk for low-carb diet decreased if the substitution was plant-based protein and fat. So what are the other things that we can do to help patients with their diets? We can use meal replacements, and this can include shakes, bars, frozen entrees. Patient can self-purchase. You could potentially carry these in your office, but they're calorie controlled and they're stimulus controlled. And there's lots of different kinds that you can purchase and that patients can purchase. And there is data to support meal replacement use. So this was a review that looked at multiple different trials and essentially found that when you used meal replacements versus diet only or diet plus support, you found that there was significantly more, higher chance of getting 5 or 10% total body weight loss if you used a meal replacement in addition to whatever other component you were studying, either support by itself or just the diet by itself. Now switching gears to talk about exercise for just a minute. I like this study. It's an older study, but it's a post hoc analysis that looked at patients who were in a behavioral therapy program for weight loss. And what you can see is that when they separated patients out based on the amount of exercise they got, patients who exercised more than 150 minutes per week had more weight loss in the first 6 months. But when we look at weight loss maintenance out to 18 months, patients needed to exercise more. So those who got more than 200 minutes per week had significantly more weight loss maintenance than those who exercised less than that. All right, now we're going to talk about behavior modification for a few slides. And essentially, behavior modification tries to change those behaviors that prevent you from losing weight or keep you in an excess weight state. And there's multiple pillars for this. That includes self-monitoring, problem-solving, stimulus control, social support, cognitive restructuring, thinking, which is thinking positively, and relapse prevention. But the most important of these is probably self-monitoring. So in a systematic review of 22 studies, more frequent and complete self-monitoring of food intake, exercise, and body weight was consistently associated with more weight loss. And in a post hoc analysis of a randomized controlled trial, including 3 arms, that he'd either behavioral therapy alone or behavioral therapy plus liraglutide or behavioral therapy plus liraglutide plus meal replacements, in a linear regression model controlled for treatment group, only adherence to self-monitoring predicted weight loss at 52 weeks, and patients who completed 100% of their food records lost 12.4% more weight loss than those who completed 0%, just again highlighting the importance of self-monitoring. And lifestyle therapy can be administered by multiple different people: dietitian, psychologist, behavior coach, exercise professional, physician. In-person and over the telephone may yield similar results, but less via internet only, where you don't have a person on the other end that you're interacting with. Intensity of lifestyle intervention does matter. High intensity gets more weight loss than moderate intensity, and low intensity probably doesn't get significant weight loss. There does not appear to be a difference in weight loss between individual and group sessions. So now let's talk about steps for pharmacotherapy. So first, you want to stop medications that cause weight gain. You want to identify patients who will benefit from weight loss medications, and then choose a weight loss medication. Once you've done that, you need to determine whether or not you should continue the medication. So for the first step, this is something that a lot of people don't necessarily think about, but you want to try to stop medications that cause weight gain if you can. So on reviewing the patient's medications, look for those that can cause weight gain and identify if an alternate medication can be used. And you may need to review this with the patient's PCP, their neurologist, or psychiatrist regarding change in medication. The second step is to identify patients who will benefit from weight loss medication. So anybody with a BMI of greater than 30 or greater than 27 and at least one obesity-associated comorbidity who have not achieved targeted weight loss with lifestyle therapy alone could benefit from a weight loss medication. You also can use it to prevent weight gain after a device is removed for patients who have not achieved targeted weight loss with endoscopic bariatric therapies or bariatric surgeries, and patients who have regained weight after endoscopic bariatric therapies or bariatric surgery. There are multiple medications that can be used to treat obesity. Couple of facts: less than 10% of patients take orlistat for at least a year, and that's primarily related to the side effects from that medication. Phentermine is only approved by the FDA for 3-month use. You can use it for longer than that. You just have to tell patients and put it in your chart that you've discussed the fact that if you use it for longer than 3 months, it's considered off-label use. Semaglutide was approved in June of 2021, gets the most weight loss compared to the other medications that have been approved specifically to treat obesity. But it's still plagued by issues related to production. So not all patients are able to get it filled, even if they get it covered by their insurance. And when I talk about weight loss, I usually like to talk about the percent of subjects that reach certain levels of weight loss, because that gives patients a better idea of what are the chances that I'm going to get good weight loss with this medication. And for semaglutide, over 80% of patients, almost 90%, get 5% total body weight loss on this medication. And you can see it's less than that for all of the other medications listed here, in addition, including liraglutide, which is the other GLP-1 receptor agonist. When it comes to getting more than 10% total body weight loss, again, semaglutide is still the leader on the board, with almost 70% of patients getting at least 10% total body weight loss, and 50.5% of patients had 15% or more total body weight loss at 68 weeks. Tirzepatide is the newest kid on the block, and that's actually a combination of GLP-1 receptor agonist and a GIP receptor agonist. It's not yet approved by the FDA for weight loss. It's currently only approved for diabetes. Ramp-up dosing is over 5 months, just like semaglutide. It is a combination of the glucagon-like peptide 1 and glucose-dependent insulinotropic peptide, or gastric inhibitory peptide receptor agonist. And you can see that patients who completed the trial and got 15 milligrams of tirzepatide got 22.5% total body weight loss. Those in the intention to treat analysis still got 20.9% total body weight loss. So the most weight loss of any of the drugs that we have so far. But a lot of these drugs are expensive, and the off-label, cheaper medications may also work for patients. So this study actually looked at the combination medication Qsymia versus phentermine and topiramate alone. And what I want to draw your attention to is that although there was higher amount of weight loss with the combination medication, if you look at phentermine and topiramate by themselves, about 50% of patients got more than 5% total body weight loss with phentermine or topiramate, and about 22 to 25% of patients got more than 10% total body weight loss with phentermine and topiramate prescribed for off-label use for long-term. And again, these medications are cheap, so they may be options for patients who can't get coverage for the more expensive medications. When we look at off-label use for long-term phentermine, this is a study that was a retrospective analysis that included almost 14,000 patients and was divided into short-term on-label use, so that's 3 months, short-term intermittent use, medium-term intermittent use, or medium-term continuous use, or long-term continuous use. And you can see that at 24 months, for patients who were doing long-term continuous use, they got the most weight loss, either at 12 months or 24 months. If you look at just the patients who are responders, so those who got at least 5% total body weight loss at month 3, you see that at 24 months, there's 10% or over 10% total body weight loss on average for patients who continued this long term. Heart rate increase was seen in the medium-term continuous group at 6 months, but not at 24 months. Blood pressure increase was seen in patients with baseline hypertension, but by 24 months, blood pressure was lower in the long-term groups compared to the short-term group, and there was no difference in cardiovascular disease or death. Having said that, these were all patients that likely didn't have significant cardiovascular disease risk factors before starting this medication, since this is a retrospective analysis of patients who were taking these medications clinically. Medications can also be used again to help with weight loss after endoscopic or surgical procedures. And this looked at this slide has data from 2 different studies, one looking at endoscopic sleeve gastroplasty that offered liraglutide at 5 months after ESG, or patients who were randomized to get placebo or liraglutide starting 6 weeks after surgery to 6 months. And what you can see is that liraglutide increased the amount of weight loss that we see both in the endoscopic sleeve gastroplasty group and in the sleeve gastrectomy study. We can also use medications to help with weight regain after bariatric surgery, and this is a retrospective analysis that was published in 2017. So they didn't include data on the GLP-1 receptor agonist, but you can see that in this study, only topiramate was successful in getting patients to 5, 10, or 15% weight loss in patients who had regained weight after bariatric surgery. So it's an off-label use for this indication, but it is effective for patients. And higher weight loss was achieved when medications were started at the weight loss plateau instead of after significant weight gain. Now, there are contraindications to the weight loss medications. You can see these here. Both liraglutide and semaglutide have similar contraindications because they are both GLP-1 receptor agonists. And the things that you really want to watch out for are the gastroparesis, history of pancreatitis, and history of thyroid cancer. So our third step in choosing a obesity pharmacotherapy is to choose a weight loss medication. And so you have to remember that there are multiple uses for some of these medications. If a patient has diabetes, you may want to use liraglutide or semaglutide. If they have depression, you may want to consider naltrexone and bupropion. If they have migraines, you want to consider phentermine and topiramate, because topiramate is effective for treating migraines or suppression of migraines. You want to make sure they have none of the contraindications, that the patient is willing to stay on the medication long term, and that they are able to pay for the cost of the medication, because some of them are very expensive if they're not covered by insurance. And you do need to counsel patients that they have to stay on these medications long term if they want to maintain their weight loss. This is an older study that compared placebo to orlistat, but this is similar to all of the other drugs that we know of right now, is that when you stop the drug, you start having weight regain and will eventually get back to the same amount of weight loss that you would have gotten if you were in the control arm. So you have to stay on it long term. The fourth step of obesity pharmacotherapy is to determine if you should continue the medication. And this is pretty simple. Patients need to achieve at least 5% total body weight loss by 3 months to be considered a responder and to not have significant side effects. You also need to make sure that cost is acceptable to the patient, because if it's not, they won't be able to stay on it long term. So in conclusion, lifestyle therapy includes diet, exercise, and behavior modification. Macronutrient content likely does not significantly affect weight loss, but number of contacts with behavior coaches does. Self-monitoring is one of the most important pillars of behavior modification. Exercise helps with weight loss, but is more important for weight loss maintenance. And there are several steps to obesity pharmacotherapy, including stopping drugs that cause weight gain, identifying patients who will benefit from weight loss medications, choosing the weight loss medication, and then determining if you should continue the weight loss medication. Multiple medications can be used for weight loss. Semaglutide is the most effective now, but tirzepatide will take over as the most effective when it's approved by the FDA. Other weight loss medications, however, may be more cost effective because they are lower in cost than the newer medications. Thank you.